All right, let's jump right in. Today, we're tackling a really critical topic for anyone in medicine: the connection between inflammatory bowel disease and the risk of developing colorectal cancer. Honestly, understanding this is a huge part of taking care of our patients, so let's get to it.
So, it all boils down to this one question, right? It seems kind of strange. How does a disease that's all about inflammation in the gut actually create a path to cancer? That's the puzzle we're going to solve today. Okay, so first things first. Before we can even talk about cancer risk, we have to be on the same page about what inflammatory bowel disease, or IBD, actually is. The first thing to remember is that IBD isn't just one single disease. It's really an umbrella term. It mainly covers two major conditions you've definitely heard of: Crohn's disease and ulcerative colitis. And the one thing that links them, the common denominator, is that chronic, persistent inflammation somewhere in the GI tract. Okay, now if you're studying for your boards or you're on your GI rotation, this slide is pure gold. You have to know the difference. Here's the key. Ulcerative colitis, or UC, is predictable. It's only in the colon, and the inflammation is continuous. It always starts down in the rectum and just works its way up. Crohn's, on the other hand, is a wanderer. It can show up anywhere, from mouth to anus, and it's known for these classic skip lesions, where you have a diseased patch right next to a totally healthy one.
So now that we know what we're dealing with, let's get into the main event. How does this constant, smoldering inflammation actually manage to flip a switch and turn a normal cell into a cancer cell?
You know, the easiest way to picture it is like this. Imagine that chronic inflammation is just constantly poking and annoying the cells that line the colon, day in, day out. These cells are designed to heal and replace themselves, but when they're under that much constant stress, the repair process starts to get, well, sloppy, and mistakes start to creep in.
And this slide really lays out that whole journey. It's a sequence. It starts with that chronic inflammation. That leads to cellular damage, which causes errors in DNA. Over time, that leads to dysplasia, which is basically precancer. And if that's left unchecked, the dysplasia can eventually progress to full-blown invasive cancer. So, dysplasia. That's the word to remember. This is our big, flashing red light. When we're doing a colonoscopy and we find dysplasia, we've caught it at the precancerous stage. It's our absolute best chance to step in and prevent that patient from ever developing an invasive cancer. It's the whole reason we even do surveillance.
And that leads us perfectly into our clinical game plan, surveillance. Because we get the why behind the risk, we can now really get into the how and when of screening our patients.
I promise you, if you're on a GI rotation, your attending is going to ask you these three questions. Who are we screening? When do we do that very first colonoscopy? And once we start, how often do we need to look again? Let's break it down.
So here's the first big timeline. That clock for cancer screening does not start on the day of diagnosis. We actually wait about 8 to 10 years after the initial diagnosis. That's the evidence-based window where the risk starts to climb, making it the perfect time for that first really important surveillance scope. Now, what's so interesting here is that this is not a one-size-fits-all approach. It's all about how much of the colon is affected. If a patient just has inflammation in the rectum, we generally don't recommend surveillance. But if they have extensive disease, like pancolitis, we're talking about a scope every 1 to 2 years. And then there's this really important exception: patients who also have a liver condition called PSC. Their risk is so much higher that we start scoping them immediately at diagnosis, and we do it every single year.
Okay, so we've really hammered home the inflammation pathway, but that's not the whole story when it comes to colorectal cancer. We also have to think about genetics. And there's one major hereditary syndrome you absolutely have to know about. And that would be Lynch syndrome. This is the most common inherited reason for colorectal cancer, and its mechanism is totally different from IBD. It has nothing to do with inflammation. It's caused by a genetic mutation in something called mismatch repair genes. Basically, the body's DNA spell checker is broken, which lets errors and cancers develop way more easily. And don't just brush this off as some super rare thing. Lynch syndrome is responsible for about 3% of all colorectal cancer cases. That's a huge number. You will definitely see patients with Lynch in your career. And for your exams, these are the classic features to lock in. The age of diagnosis is shockingly young. The average is just 44 years old. The tumors love to hang out on the right side of the colon, and these patients are also at a much higher risk for a bunch of other cancers, especially endometrial cancer in women. All right. Let's pull all these threads together and talk about what really matters for us as clinicians. Prevention. How do we stop this whole process before it even gets started?
This, right here, this is the single most important thing to take away. Yes, surveillance is great for catching things early, but true prevention, stopping the cancer from ever forming, comes from treating the root cause. When we effectively treat a patient's IBD and get that inflammation under control, we are actively practicing cancer prevention. And this leaves us with a really exciting question for the future. Our treatments for IBD are getting so much better. We have incredible biologic therapies now. So the big question is, are we finally going to see the rates of colorectal cancer in these patients start to plummet? It's something everyone in GI is watching very closely, and we're all hoping the answer is a resounding yes. Thanks for tuning in.